that you're removing and what the wound looks like before and after with measurements as well. So all of that is part of what we do in the wound center. And again, once a week, these patients get seen, and it's important that they get followed and aggressively debrided. Now, getting back to step one, you are not, or you shouldn't do a debridement without establishing good blood flow. And we see this all the time, where they start aggressively debriding the wound, and the blood supply is zilch to the area, and that's when you get into trouble. That's when you start ending up losing bits and bits and bits of the patient's lower extremity. Now, this is obviously dear to my heart as an endocrinologist, and we see this all the time. We have people walking around, and we're using all of our resources, all of our advanced, we go as far as the advanced modalities, which we'll get to, and they're walking around with hemoglobin A1Cs that are 11, 12. In other words, poor blood glucose control. Now, we are wishful thinking there when it comes to what the appropriate hemoglobin A1C or daily blood glucose should be. Obviously, if you're a diabetic, it's very difficult to have hemoglobin A1Cs that are under 7 or daily blood glucose under 100. But that's what we're targeting for. And if you're not targeting for the best, you're not going to get there. So you might as well target for the best and try your best along with the patient to get them there. And it's important that we evaluate the patient, and even though we're just focusing on the wound, it's important that we make sure that their blood sugars are being addressed as well, because having them walk around with high blood sugars while providing all of this care is not going to get you the best outcome. So again, it's key. And since you got them under your control, weekly until the wound heals, you've got a chance to give them additional education, explain to them the importance of doing daily, twice a day, 3 times a day finger sticks, and obviously you've got a chance also to give them additional instruction on the type of diet that will not only help with their blood sugars, but also help with their wound healing. So again, it's key as far as a key step in getting these wounds to heal is to address their nutritional and glucose status. Now, this is an area that I find over the years, we always seem to forget. And that is, properly offloading the area where the wound is. And obviously, whether it's on the plantar aspect of the foot, plantar aspect of the toes, or the forefoot, or if it's a arterial lesion, again, any kind of footwear that is hitting against, causing shearing of that area will cause the wound and keep that wound from healing. So the only way you're going to get that wound to heal is that you offload that area. And there, we'll see there are different devices, but part of your team in the wound center, again, we believe in a multidisciplinary team approach to taking care of these patients. Part of your team needs to be, whether it's the podiatrist, the podortist, the orthotics, someone who's going to address the offloading of these patients. Again, specifically for the lower extremity, but also, and these are some of the devices, and for the record, the standard of care, the gold standard for lessening the pressure on the plantar aspect of the foot is the total contact cast. Way back when we first started, when we were in Staten Island, we had these 2 fellows who did their training down here in Louisiana with Brandt, and learned how to put total contact casts on lepers coming from the Caribbean, coming here to, I think it was Baton Rouge, the public health hospital down there, and they learned how to put these casts on. Again, these people are completely neuropathic. So are our diabetics. And if you put any additional pressure on any given part, or put the cast on wrong, by the following week, you got another ulcer. So they came up and they taught us, and that's, we would just allow them to put on those casts. We were known for the longest time as the cast, the total contact cast center, because we had total contact casts on everyone. Now it's much easier to apply. We have kits, we have companies that provide you with all of what you need. Obviously, as providers, as physicians, you are responsible, but now we have nurses and nurse practitioners that help put these casts on. We have walkers, we have all different devices that will lessen the pressure on the area of the foot that is broken down. But again, it's not just a foot ulcer. Obviously, for pressure ulcers, there are devices that are available to help lessen the pressure on the body. Patients that are bedbound or wheelchair bound, you have the ability to lessen the pressure in the area so that you won't get skin breakdown, and if you do have skin breakdown, you'll have a chance to heal it. So again, these are all devices that you need to be part of your treatment protocol in treating these patients and getting these wounds to heal. Now this is a step that is quite important, and we tend to also overlook. Not too long ago, in one of our centers, a patient wrote a letter of complaint, rightfully so, because 4 physicians saw the wound. Patient was a diabetic. First thing they did, they did evaluate the blood supply. They evaluated some of the steps that we talked about. 6 to 8 weeks went by with them debriding every week, and the wound just kept getting worse and worse and worse. They just did a superficial culture. Unfortunately, they didn't do a biopsy, and the wound just kept getting worse. And then after 6 to 8 weeks, the patient, the family got a little nervous, went to a plastic surgeon. The plastic surgeon took a look at it and had a eureka moment and did a biopsy, and it was pyoderma gangrenosum. And obviously the debridement was not the right thing to do. So again, think of other issues that the patient may have. Obviously having diabetes, but other autoimmune diseases, other connective tissue disorders, vasculitides that might be contributing to the wound. That if you don't address those issues, if you don't address those other comorbidities, the wound will never heal. So again, the proper treatment for that patient would have been either local or systemic steroids. Sometimes it works, sometimes it doesn't. Obviously treating whatever super infection that might have been there. That was the proper approach, not a debridement. Actually, like I said, the debridement only got the pyoderma angry. So again, think of other comorbidities, other disease states, whether, like I said, is autoimmune or other connective tissue disorders, scleroderma, Raynaud's, lupus. Those are all other diseases that, again, will cause wounds and keep the wound from healing. And that's why we have multiple assessments, both nursing assessments along with our, as providers, assessment and plan. We also have everyone do it all over again after 30 days if the wound hasn't healed yet. So this way, you might pick up something that you didn't pick up the first time around. Now, we talked about the dressing selection. Now you've fully evaluated the patient. You've established a good blood supply, plus or minus infection, and you're treating it. like I said, you're offloading, you're doing everything that you need to do. You've assessed for other comorbidities, and now you got to pick the right dressing. And this is key because you need to put the wound that you just debrided in an environment where you're going to foster what is needed for that wound to heal. When you select that dressing, and in fact, I'm not going to show you which company, or else I get into trouble with the CME, but there's different devices that some of the companies will give you where you kind of match what the wound looks like and different variables, and it recommends what dressing to use on that particular wound. I personally try to avoid that. I don't, as a chief medical officer of the company, and I will tell you there's a few of our staff physicians on the panel that are here. I try to stay away from a cookbook approach to treating these wounds. In fact, I'll tell you a little story. Way back, we had a center in the Chinatown area in New York where we had a lot of the local Asian population coming to the center, and ma'am, you are not to use honey on your wound. Please do not use honey on your wound. I mean, God knows what flies and all sorts of bugs. Don't use honey. Well, a month later, Meta honey was out there and it was on the market and everybody was using it, using honey. So the point being that serendipity and using creativity in our center is key. I think we're always finding the latest and greatest and the newest dressing or device that might help us heal these wounds. So again, you do have some flexibility, but for those who need some guidance, there are plenty of different devices out there that can help you. And in fact, there's so many different products out there that, this is actually one of my first slides that I put together about 25 years ago. And at the time, I used to laugh at that guy because of the helipad that he had on his head. And now he's looking more and more like me. Because there is a huge array of different products that are available, and sometimes it's hard to pick the right one for the right wound. But again, like everything else in medicine, you could probably bring it down to 2 or 3 in each category and choose and develop an experience with the different products. And like I said, there's new ones coming out every day. Now, after doing the full 6 steps, most of the time, actually huge majority of the time, you're going to get that wound to heal. You don't need to go as far as any of these advanced modalities that we're going to now talk about. In fact, looking at our data, and unfortunately, there's very little benchmark data out there when it comes to wounds. There's nothing that the NIH publishes. There's nothing that our competitor puts out there in the centers that they manage. We have our 250 centers, and we have data that we have, in those centers where we can compare East Jefferson with the other 249 centers and give them an idea of how they're doing and how well they're healing these things. And we're hoping, to put that out there and publish them. But I will tell you that in 92% of the time, we will get our wounds to heal without using advanced modalities. It's that 8 to 10% of the time when we don't get them to heal using the conventional steps of wound care that we now have to add the advanced modalities in order to get that wound to take that last step, no pun intended. And the advanced modalities, which we'll talk about, of which one is hyperbaric oxygen therapy, which we've talked about in the past, but we'll go over it again. That's one of the advanced modalities. For those of you who are not familiar with it, we have chambers here in this center. It's based on gas laws. If you recall way back in your high school and college physics, it's Henry's law, which pretty much states that increasing the pressure around the gas will make the gas more soluble in solution. And in this particular case, the solution is the plasma, and it's the dissolving in the plasma, in the serum that we think is going to improve the wound healing process. And it's not very efficient. Obviously, we've developed the hemoglobin as a more efficient way of delivering oxygen, but you can't get our hemoglobin more saturated than 100%, right? So, and in most cases, even in patients with COPD, you're pretty close to 90% saturation. So it's not the additional saturation of the hemoglobin, but it's that additional oxygen soluble in plasma. For those of you who are not familiar with oxygen, with hyperbaric oxygen, this is not hyperbaric oxygen therapy, okay? And you'll see this, and people are still using this, and vendors are still trying to sell you this as hyperbaric oxygen therapy. This is not hyperbaric oxygen therapy. Unless you want to hyperoxygenate your genitalia, this is not hyperbaric oxygen therapy. Okay, you need to be total body in the chamber in order for it to be hyperbaric oxygen therapy. Again, these devices appeal to people because obviously you can use it at bedside, you can do a lot of different things that you can't do with a hyperbaric oxygen chamber. This is hyperbaric oxygen. Your whole body. You can say what you want about Michael Jackson. He knew what hyperbaric oxygen was. He was in one of these, and he actually had a tech make sure that he got his full dose of hyperbaric. And how does it work? And this is a study that was done a few years ago by our friends over at UPenn, Margolis and Tom, looking at the basic science of hyperoxygenation, and it is multifaceted. It works on many different levels with full expression at the biomolecular level. And it works by obviously working directly on some of the bacteria, especially the anaerobes, by creating superoxide radicals that directly are bactericidal. It also revs up the ability to clean up, whether it's debris or actual bacteria, with increased and more efficient phagocytosis in patients that have suppressed ability to phagocytose, the bacteria in our patients with diabetes, for example. It improves and increases collagen deposition, so you have additional collagen being delivered to the wound, so you start filling up that wound. Obviously, most importantly, angiogenesis. Hyperoxygenation will stimulate and improve angiogenesis, and it also revs up the whole cellular energy metabolism. So again, this study, for those of you who are looking for studies to back up basic science of hyperoxygenation, this study is definitely something that made some of the scientists among us more comfortable with using hyperoxygenation. Now, this is a statement: all chronic wounds would benefit from hyperoxygenation. I've always put it out there in every single one of my presentations, and no one's ever argued against it. Obviously, it makes sense. You hyperoxygenate, the wound. It will help in getting it to heal, especially those that have stalled. But not all wounds need to be hyperoxygenated. And in fact, a lot of the third-party payers, including CMS, have put a limit or have pulled out a number of different wounds or different indications that will benefit from hyperoxygenation, and that is what they will pay for. And again, the biggest of all of those, we go back, is the diabetic wound of the lower extremity. I would say about close to 70% of those patients that we treat with hyperbaric oxygen therapy fall under that category there. It has to be of a certain severity, has to be Wagner 3 or greater, and it has to have failed 30 days of conventional therapy, which were those first 6 steps that we talked about, after which you add hyperbaric oxygen while continuing to follow the steps. Other advanced modalities, obviously the use of so-called skin substitutes. We're not supposed to use that anymore. Human cellular tissue products is now, and tissue-based products is what the terminology is. So many different types, so many different origins of where the tissue comes from. I look at it and I usually put it under the dressing category, but in reality it's a separate category. It is an advanced modality. It's seen as an advanced modality by the third-party payers. So in order to get to put some of these products on these patients, you really need to be part of our wound center.